Okay, we'll talk about a few other obstetrical emergencies, one being meconium stained fluid. At some point, it's a danger sign of pregnancy because at some point the fetus could have lost sphincter control due to a fetal heart rate decel, not enough oxygen in the baby, so this would allow meconium to pass into the amniotic fluid. With meconium stained fluid, sometimes if the cord's compressed, it can result in hypoxia, which we just said that stimulates the vagal nerve. But it doesn't necessarily mean that the baby's in current distress. It could be distress from an earlier time in pregnancy that's not currently going on. It is an ominous sign if it's associated with current variable decels or late decelerations. If it's meconium stain, there's a suction protocol. You suction below the cords with the endotracheal tube if the respirations are depressed, muscle tones are decreased, or the fetal heart rate after birth is less than 100. Amnioinfusion could be done. It's not always done, but it could be done to help flush that meconium out and make that fluid clear. I'll talk a little bit more about an amnioinfusion here in just a second. So an amnioinfusion can be done for two reasons. A meconium stained fluid, not routinely done, but it could be done. A couple things have to take place for an amnioinfusion to occur. The membranes have to be ruptured, okay? You also have to have an internal uterine pressure catheter inserted, IUPC. This is an example of an IUPC. It looks think of it kind of as a Foley. Depends on where you work. If you can, the nurse can insert it, or a doctor has to insert it. But it's inserted through. I'll raise baby up here. Through the cervical opening, okay, and it's inserted along the uterine wall, in between the uterine wall and the actual fetus. Okay, so something like that. Okay, pretend there's a uterine wall here. Membranes are ruptured. Okay. For meconium stained fluid, you take normal saline, and these intrauterine pressure catheters have access just like an IV fluid, IV device would. You hook your IV fluids up to the IUPC. And the normal saline is administered and given inside mom's uterus. So you're flushing it with a bolus of normal saline, and if it's for meconium stained fluid, hopefully to flush that meconium out until the fluid is clear. That's one of the main things you want to monitor for. If you're putting fluid in, you want to make sure you're getting fluid out. Otherwise, the uterine wall will expand and eventually lead to a uterine rupture. Now, another reason you might do an amnioinfusion is for oligohydramnios, which means not enough amniotic fluid. What happens if we don't have enough amniotic fluid? How do we know we don't have enough amniotic fluid? Well, a lot of times you will see cord compression. So let's pretend there's not a whole lot of amniotic fluid here. When mom's uterus contracts, it's going to compress that cord easier than if there was a lot of cushioning there. Okay? So if the cord's getting compressed, you see recurrent variable decelerations if there's not enough amniotic fluid. So an IUPC would be inserted, normal saline hooked up. You would administer normal saline into the uterus, provide extra cushioning for the baby, okay, and prevent those reoccurring variable decels. So the meconium stained fluid or reoccurring variable decels are the reason behind your amnio infusions. Again, you always want to check for fluid return so you're not expanding that uterus and causing a uterine rupture.